So we've been asked to talk about links and referrals. So in our roles in East Lancashire, we thought it was important to not only educate the staff on what a veteran is and how to refer, but we needed to make those local links with some of those organisations that we have, fortunately, in and around East Lancashire. So we have lots of breakfast clubs. The three main football clubs like Burnley Football Club, Blackburn Rovers, Accrington Stanley, they all have a veteran programme, and they deliver a whole host of opportunities for veterans in our area. So we're very lucky. So we thought it was important to get out and visit some of those organisations, get ourselves known, wearing T-shirts so people can see who we are. And also, we thought it was important to speak to veterans themselves, ask them what it is they want of us as an NHS organisation, what we can help support with. So ELHT's ethos is safe, personal and effective care. So we thought that making these links with these organisations, we could deliver that ethos. And it's just important to get to know your local population. Next slide, please.
When we were approached about kind of doing this together, to looking at the standards, we kind of felt it was really important to kind of do a joint presentation to kind of look at links and referrals from both the general hospital perspective and NSFT is a mental health trust, so kind of presenting ourselves and what we are doing from a mental health perspective and how we are ensuring we've got the right referrals and the right links with those around us and to support veteran mental health. So within NSFT, we're very fortunate that we are part of the Courage network. So we lead on a high intensity service. So we work incredibly closely with our Courage colleagues in different trusts. And then one of my TILS colleagues and a lot of my TILS colleagues are here today. And that is a big part of how we link in to ensure a veteran gets the right mental health care depending on their need. So even though we're kind of from different trusts, it's really important that we work collaboratively to make sure that the veteran has the right access and the right referral pathway for their needs. So we're very fortunate with that. And within our high intensity service, we work in partnership with Walking with the Wounded, Mental Health Matters, to make sure that what we are offering is an holistic approach to their care. So we make sure that they get the right service that they need depending on what's impacting on their mental health. So it's important to have the right referral access and the right links to the right people to offer the right care. Within NSFT, we also have the Veteran Integrated Service, which is a veteran-specific enhancement service. So any veteran who is under secondary care is entitled to work with us as well, which is an incredible opportunity to be able to offer that enhancement of service. And we work again with Walking the Wounded and Outside the Wire to do this, because we acknowledge and address that veterans have multiple needs. And we want to make sure the right links are available for them to make sure their care is being met. So Walking the Wounded, they're experts in holistic and social care needs. And Outside the Wire work as a local service with substance misuse. So we make sure that we can address what matters. We're also working directly within the community, within our VIS service, and we've set up local support groups. So every day there is a cafe or an environment where veterans can come along, talk together, speak together, and get that peer-to-peer support, which hopefully prevents secondary investment and secondary care. So we're looking at how we can stop veteran mental health escalating and work with the community and those around us to support veterans before kind of things escalate.
So what we decided that a veteran can't be seen unless a robust referral process is in place. And our trust sees on average about 700,000 patients a year, and a proportion of which are identified as veterans. So the first step in any of the referral processes was to get the staff on the wards aware of what the referral process is and how to do it. So we've identified an internal referral process. Every ward has what we call a crib sheet that is up by the nurse's station. It basically says how to go on the electronic system and how to do the referral. Now, we all know nurses are very busy, and they don't want a referral process where they have to sit down and write reams. So what we did, it's one button. You press the button, it refers on, it puts a little medal on the patient, and it goes directly to Sid and myself. They don't need to write anything, they don't need to do anything. It's immediate, and we're a 5-hospital trust, so it doesn't matter where the patient is. They can be in Accrington, Blackburn, Pendle, Clitheroe, Blackburn. It comes immediately to us, and we, as a 2-man team, will go out and see whichever veterans are about. One of the things that we did, as Sid mentioned before, is we've put it on the Learning Hub. And we've also, our trust, in a prequel to a CQC visit, we have a NAF. And the NAF is a nursing assessment performance framework that every ward has to undergo. They have to pass it. No ward wants to fail a NAF. So the NAF team will turn up on your ward, speak to any member of staff and say, are you aware of Veteran Aware? If the staff member goes, yes. What is it? Do you know how to refer to the Armed Forces campaign? Yes. How? And they have to follow this procedure. This will start in our trust, well, they said end of September, beginning of October. My advice is, if you do have an internal process, please get it out to your wards. So I've emailed every ward manager, every matron. Sid's been on the Nursing and Midwifery Forum to get it out there. We've got posters up so that if a ward does fail, it's not our fault.
So since the 1st of January this year, the slide does say 430, but I think at this moment in time, we're up to about 460 patients that Fiona and I have seen face-to-face in that time. And I think I've probably got about 9 waiting for me when I get back to my office tomorrow. So it's probably close to 470, to be fair. And that's across all our 5 hospital sites. So as you can imagine, I do a lot of mileage and a lot of walking. So it keeps my steps up, which is okay. So the majority of the people that we see or have seen so far have been over the age of 80. So those that have served national service. Now, a lot of those that serve national service don't consider themselves a veteran when they absolutely are. You know, so we've talked to them and they've said, oh, I only served national service for 2 years. But you'll find that in that 2 years, they went to places like Malaya and Aden and Suez and places like that, you know, and they absolutely did, you know, our country a service in that 2 years. So of the 470, as it probably is now, we found that 10% of those patients that we saw were for mental health reasons and mainly came in through our ED departments. 60% were in for medical reasons, 22% surgical, so they came for some kind of procedure, and 8% needed some kind of social assistance. Now, we've helped people with work alongside the likes of the British Legion to get handrails in front of their front doors, leading up to steps, that kind of thing. And we've signposted those people to the necessary support that they've needed. Next slide, please, David. Thank you.
This slide shows our projection and actual. So from 2020 to December 21, pre-SID, my time is pre-SID, I saw 202 veterans in a year. I'm the Armed Forces lead. I have a job, which is the site manager job, so this is like extra. So it quickly became, you know, current to me that I couldn't do this on my own. So that's when I applied to the Covenant and I got to SID. My projection then from SID, I was thinking very naively that if I saw 200, 2 of us could see 400. What I didn't take into account at that time was all the links that we were making, all the pathways into the different services, into the different breakfast clubs, into the different outpatients, things like that. So my projection of 400 for December 22. We've excelled that already. So I've thought, I think it's going to be more like 600 we will see face to face by December 2022. And if we carry on that projection, we're going to be seeing 800 by the time Sid's secondment finishes, and I can't do it on my own. One thing we have found that's been very good is Sid's military background and my nursing background. So Sid can identify with all the veteran services and the links and talk on that level and get the bonds there. And then I chip in with any clinical expertise or anything clinical. So we kind of pincer movement everybody. Next slide, please. When talking about that, obviously we need to talk about finances, and the trusts like finances. So based on what we have seen and the amount of people we've seen, in ELHT it's £642 per 24 hours for a patient. That's without treatment, that's just the bed. Now, an average stay, when I spoke to the discharge facilitation team, they said when a patient comes in and is admitted to an acute ward, they put down 3 days. That's the average. People maybe longer, but 3 days is the average. So based on that, you're talking nearly £2,000 per person for a 3-night stay. So from January to April, pre-SID, I saw a mission avoided for patients. So that saved £7,704 for the trust. That's by referring people to the mental health service at the front door, homeless charities that could take somebody, but somebody that was in need of a veteran service that I could stop at admission for. Post-SID, we've seen 17 more admission avoidances. So that's another £32,000 for the trust. So the actual amount saved to date is £40,000. Now, we're here for the patients. We're here to make the patient's journey better. That's our primary thing. But obviously, if we can save the trust money as well by linking into the correct services and getting the patients to the correct services and stopping an admission, we double whammying it. And so based on that new projection post-SID, I'm looking at 60,000 will save the trust to December.
So in NSFT we don't have a SID. However, we do have a great team of armed forces practitioners, and I would really suggest, as has already been said today, having that protected time for individuals to build those links, build that therapeutic relationship, and build that connection with your veteran community, within your hospitals, within your community, is so invaluable and facilitates the real support that can be given therapeutically, which we know impacts on people's mental health, their well-being, and then ultimately their physical health as well. So as I've said, we have two specific services within NSFT. We've got the Veteran Integrated Service and the High Intensity Service. Both of those services are co-produced with charities. And I'm not saying that's feasible for other NHS trusts who are sitting here today, but for us it has been invaluable at being able to build those links. We have to trust, we have to know that our third sector partners are incredibly skilled at the jobs they're doing and have got their own incredible networks. And we work with them to ensure we're able to offer the best care and the best networks we can. And by working with them collaboratively, we have weekly meetings in both services where everyone joins, both our clinical staff and our third sector staff, and we make sure that that veteran is receiving all the care they are entitled to. And that shared knowledge between them is given out so that our partners, our subject matter experts in social and economic work, in substance misuse work, or in NSFT, as mental health professionals, we are working together and creating those really strong links across the community to make sure that a veteran gets the best mental health care they're entitled to. So that any position you are in, to work with those who are already offering care, let's not redo wheels, let's join up, work together so we can facilitate the best care that's possible. And that's what we try and do in NSFT with our 2 services, is make sure we are working within our community, with our charity, refer in and refer out, so they can refer to us as well, so they know that the subject matter experts in mental health, their veteran is seeing them. And we work with our NHS colleagues across Upcourage as well, and across secondary services, to make sure things are linked up and the care is there for everyone.
So those external referral links are vital from our point of view. So when we visit a patient, we can offer them the support that they need, including the demographics of the geography where they live, because some of those icons you can see on the screen there, like the football clubs, the 2H's as Healthier Heroes. It's a local organisation in Burnley, and they look after and facilitate and house up to about 20 veterans that have found themselves in a difficult place. They keep them for about a 12-month period, put them through mental health treatment, offer them courses, retrain them, and then they can be reintegrated back into the society, once they've, got over the difficulties that they arrived with. So we thought that it's definitely the best way to go and talk to the patients, find out exactly what it is they want, and then we can then deliver that referral process to the right organisation out in the wider world. We find that because we see patients in an acute hospital setting, most patients are obviously fairly ill when they come when we go and see them. So it's vital that we have that conversation and that face-to-face visit. In my sort of opinion, and this isn't my opinion, having websites and QR codes is great, but if somebody's ill or in crisis, they're not going to be looking at a website or a QR code. They want somebody to be there in front of them, offering them support and talking to them, and then we can then signpost them to some of those places that have QR codes and et cetera, et cetera. Next slide, please. So of all the patients that we've seen, about 10% have come in crisis via our ED departments. I've dealt with those that are homeless, alcohol, drug misuse. I found that some of them that have been homeless, we've obviously provided support for those. I've managed to acquire, as you can see in the little picture, that is a little go bag that I've acquired through a friend. One of my friends is a colonel, and his mother and father run a military charity, and this charity offers these go bags to currently serving personnel that go overseas to various places, and they very kindly donated a few to the trust. So if anybody comes in homeless, we can get them a shower, change of clothes, they can brush their teeth, that kind of thing. We can offer them support that way, and then we can then talk to them and then find out what support it is they require. Talking to local councils to get them some kind of accommodation, that kind of thing. As I mentioned earlier, Healthier Heroes, we're absolutely extremely lucky that we have in our area an organisation like Healthier Heroes that can house. We can phone them up, and they will, even if they've got no room, they will take a homeless veteran and take them on, look after them, and then provide support for them. So we're quite lucky from that point of view. Next slide, please. So I just wanted to touch briefly. You won't be able to see all of them. There's a lot of patient feedback that we've had for the support that we've provided, and I just wanted to touch on the one in the middle. When I first started this role in April, I was only in the role for about a week, and this gentleman arrived in ED having taken an overdose. He was in a very bad place. He was admitted to the ward while they tried to find out what support and medical assistance they could give him. We were called in because he was identified as a veteran. So I went and had a chat with him and detailed to him what support was out there. He didn't have a clue what support was available to him. So I then linked in with our very good colleagues at Upcourage. Ali, hello. And they very kindly worked with LSCFT, which is our sister trust, and they were our mental health service, and we got him a place in a priory hospital, and he went through a programme with them alongside the high intensity service of Upcourage, and they put him through a 12-week programme, and he came out the other side. He said me that. It does bring me a tear, because it was my very first patient that I dealt with, and I was new in the role. I had no idea myself what to do. but this chap sent me this a couple of weeks ago, just to say thank you that it saved his life. And it's not just me that saved his life, it's all those agencies, Op Courage, the Priory, the hospital itself, all working together, and they've brought him back, from adversity, basically.
And I'd just like to say that's been added since we kind of last went through this. And I just think if there's a better example of how referrals could and should work, there's not a better example of how we as a collective can now work together across trusts, across services, referring in and out of each other to make the veteran pathway the best it can be. So thanks for that. I just think it's really important to kind of really demonstrate how we're working across services. Just to finish from ourselves with NSFT, we're very fortunate that we've got the service we have, and we feel that sitting face to face with people, talking to people, having time with people, building the trust and relationships in mental health services, which we know have their own stigmas, really help a veteran communicate with us. And we're doing this in multiple ways. Not only do we have our practitioners, we have our veteran-specific services, but we've just set up a charity. And within that charity, we're then hoping to get our veterans to raise money, to empower them. And we're doing events, we went climbing the peaks, we did a big Veteran Families Day with over 70 veterans and their family members to try and break down those barriers of clinical, patient, and work together for a purpose. And people allow themselves to choose what they want us to do. Just because people are veterans doesn't mean they have the same interests by any stretch of imagination. But they often do have a community. And by able to bring veterans together under that community and that peer-to-peer support can be incredibly empowering and give us really important links in the future for their ongoing success and their ongoing recovery. So it's ensuring we've got those links with the community, vice versa, for people's ongoing recovery. We've also just had our own conference, which kind of, again, facilitated lots of engagement with local services and raising awareness of who we are and what we're doing to be able to make sure that everyone knows who we are and what is out there for our veteran community. And how we ended that conference was with some lived experiences and people standing up here, like we're doing now, and talking about the impact working with veteran mental health services had and how that had helped them through their recovery. And that's what's most empowering, really, being able to listen to people and learn from people who've got lived experiences and how we can keep developing our services because of that. Thank you very much, everyone.